And then in terms of other fractures that you may be able to see, so the literature talks about clavicles. So you could take a look at their probe, and can you guys appreciate the cortical disruption there, pointing by the arrow? And then they also mentioned scaphoid fracture. But the smaller the bone, the higher the technical challenge that comes with it. So just a word of caution there as well when you're scanning smaller bones. So in terms of limitations of POCUS, just recognize that when you're scanning around articular areas, it may be very tricky, and also around the growth plate, it could be sometimes challenging as well, because in growth plates that are closing or just recently fused, it may look like cortical disruption, but you really have to correlate with your anatomy. And then also in Dr. Punai's study, there were a few missed styloid fractures, honest styloid fractures, and so that's also something to consider if you have tenderness kind of around that area, just to be mindful of that. And then the smaller bones are also trickier. And then the last topic is around tendon injury, which is something that in pediatric practice maybe we're a little bit less familiar with because we don't see it as commonly as we do in the adult population. But the concept of it seems pretty straightforward. So on ultrasound, tendon bundles appear as echogenic parallel lines with fibrillary appearance. And so when the complete rupture is present, there's disruption in that tendon continuity, and you can't find and follow it thoroughly. But you can also have a partial tendon rupture where there's a break in some of the fibers, but the whole continuity remains intact. And so it's a partial tear. Or you can have other findings as well, like hematoma formation within the tendon, or you can find bony fragments that cause a shadow beyond it. In terms of which tendons can be scanned, I guess in theory, anything that you can reach with the probe, you can in theory scan. You just have to know your anatomy and what you're looking at. But case reports have been published for quadriceps, patellar tendon, Achilles tendon, triceps, tendons, and these were nicely summarized in the pediatric POCUS summary of evidence paper published in 2015 by Marin et al. Overall, it's just a good paper to go over for all the POCUS applications, just an aside. And so in terms of the tendon ruptures, so to give a few examples, this was a case of a quadricep rupture where on the left-hand side you see normal quadricep where there's linear intact fibers of the quad tendon attaching to the superior pole of the patella and the anterior aspect of the femur. So it's on the left-hand side it's normal, versus on the right-hand side you have the ruptured quadricep tendon that's only attached to the superior pole now, and you no longer have that attachment to the femur, and the linear fibers are lost and now replaced by an effusion there, that hypoechoic area. This is another example, and this is a patellar tendon rupture. So on the left there you can appreciate the normal patellar tendon, and the measurement is there in that blue vertical line, compared to on the right where you have the patellar tendon rupture. Notice how it's much wider in terms of the width of the tendon, and this is indicative of a retracted tendon stump. So it's a common finding in full thickness patellar tendon tears. You also at the end of that stump have this wavy appearance to the tendon and that almost edge artifact look to the torn tendon stump. These are also findings that are described for patellar tendon ruptures. This is an example of an Achilles tendon rupture. So on the left-hand side, again, you have the normal Achilles tendon, Achilles tendon, and then on the right side, you see a disruption there with a hematoma in the middle. So to summarize, for the skull, some pearls would be to remember to distinguish the fracture from the sutures by following through to the fontanelle and comparing sides, scanning beyond 1 to 2 centimeters of the hematoma and minimize probe pressure. But some pitfalls of skull fracture scanning is that if it's not there, it doesn't completely rule out intracranial injury. And if you see it there, you can't really tell the degree of the hemorrhage underneath the fracture. So you really need to use your clinical correlation to guide your decision around CTing or not CTing. And then to summarize bones and tendons, POCUS is most useful in diaphyseal fractures of the long bones, such as the humerus, the femur, forearm, elbow fractures, looking for the posterior fat pad. And you can use ultrasound to guide your fracture reduction in settings where you don't have fluoroscopy readily available. You can, if you see a case of tendon rupture, you can take a look and see. You may be able to appreciate those disruption in the tendons. But be mindful that it's less accurate in small bones, such as in the hands and the feet. And then the fractures that are close to joints and growth plates can also be tricky. So that's all for my content, but happy to take any questions or discussions around any